Heart rate. Cardiac arrest. Pulseless arrest occurs due to four cardiac rhythms divided into shockable and non-shockable rhythms: shockable ventricular fibrillation (VF) and ventricular tachycardia (PVT). Non-shockable asystole and pulseless electrical activity (P) for VF-PVT. Key to survival is good early CPR and defibrillation. For asystole P, key to survival is good early CPR and exclusion of all reversible causes. Reversible causes of P arrest: 5 H's and 5 T's. 5 H's: hypothermia, hypovolemia, hypoxia, hydrogen ions acidosis, hyperkalemia. 5 T's: tamponade cardiac, thrombosis pulmonary, thrombosis coronary, tension pneumatoria, toxins, overdose poisoning. When a patient sustains a cardiac arrest during anesthesia, it is important to remember that there are other causes on top the H's and T's to consider, i.e. local anesthetic, systemic toxicity, last, excessive anesthetic dosing, and others. For management of cardiac arrest, see appendices, A32. Intraoperative tachycardia. Tachycardia, HR, 100 bpm. Divided into sinus tachycardia, HR equals 100-150 bpm, or supraventricular tachycardia, SVT. SVT can be further divided into narrow complex or wide complex tachycardia. Narrow complex atrial fibrillation flutter, accessory pathway mediated tachycardia, paroxysmal tachycardia, wide complex VT, SVT with aberrant conduction. Causes of sinus tachycardia: shock, hypovolemia, blood loss, anxiety, pain, light anesthesia, full bladder, anemia, febrile illness, sepsis. Drugs, e.g. atropine, cocaine, dopamine, epinephrine, ephedrine, isoflurane, isoproterenol, pancuronium, and withdrawal. Hyper-metabolic states: malignant hyperthermia, neuroleptic malignant syndrome, pheochromocytoma, thyrotoxicosis, serotonin syndrome. For management of tachycardia, see appendices, A33. Intraoperative bradycardia. Bradycardia, HR, 50 bpm. Most concerning are second-degree, Mobitz type 2, and third-degree heart block, which can both degenerate into asystole. Causes of sinus bradycardia: increased parasympathetic tone versus decreased sympathetic tone, must rule out hypoxemia. Arrhythmias, see cardiology and cardiac surgery, C18. Baroreceptor reflex due to increased ICP or increased BP. Vagal reflex, oculocardiac reflex, carotid sinus reflex, airway manipulation. Drugs, e.g. suprachoroidal hemorrhage, opioids, edrophonium, neostigmine, halothane, digoxin, beta blockers. High spinal epidural anesthesia, hypothermia and hypothyroidism. For management of bradycardia, see appendices, A33. A13 anesthesia. Blood pressure. Causes of intraoperative hypotension, shock. Condition characterized by inability of cardiovascular system to maintain adequate organ perfusion and delivery of oxygen to tissues. A. Hypovolemic hemorrhagic shock, most common form of shock, due to decrease in intravascular volume. B. Obstructive shock. Obstruction of blood into or out of the heart. Increased JVP, distended neck veins, increased systemic vascular resistance, insufficient cardiac output, e.g. tension pneumothorax, cardiac tamponade, pulmonary